Good morning, everyone. Today we're going to talk about urine examination, otherwise known as urinalysis. Doctors have had an intimate relationship with their patients' urine for millennia. In the olden days, examination of urine would include smelling it, looking at it, and tasting it. Thank God we no longer have to drink people's urine in order to make a diagnosis, right? So the objectives of this brief talk are to look at what constitutes urine examination, and then we'll look at the correct way in which to do a urinalysis, and then discuss some of the possible causes of abnormalities seen on urinalysis. A full urinalysis would include physical examination of the specimen, carrying out some chemical tests on the specimen, and then finally looking at the specimen under microscopic examination. So as I said, the first part involves macroscopic examination, where we look at the color of the specimen, the smell of the specimen, and then the second part involves use of the urine dipstick, and then finally you examine the specimen or the urine under the microscope. So like every other specimen, for it to yield useful information, the collection of the specimen must be done correctly. So urine that is meant for urinalysis ideally should be collected using midstream urine, but I do appreciate that there are circumstances in which this may not be possible, like for example, if one is dealing with very small children, in which case one would use non-invasive methods like placing a urine collecting bag on the perineum, or in other circumstances like in the ICU when you're dealing with unconscious patients, you may have to catheterize the bladder, and in very rare circumstances you may do a suprapubic tap to obtain the urine specimen. So ideally this should be early morning voided urine. Why? Because this urine has been sitting in the bladder overnight and more closely approximates a 24-hour urine collection, tends to be more acidic and concentrated, and those two properties will help to preserve the formed elements, the cells in the specimen. And ideally, the specimen should be examined as soon as it is collected, but certainly within 2 hours. If you think that you will not be able to do the urinalysis, do the microscopy within that time, then you would need to store the urine at 4 degrees Celsius and refrigerate it. Macroscopic examination firstly has to do with the color of the urine. Normal urine has this pale yellow to dark yellow or amber color, which is due to a pigment known as urobilinogen, which is a product of heme metabolism in the liver. But bear in mind that this normal color varies depending on the hydration status of the patient, so the concentration of the urine, as well as certain medications, and will also change in different disease states. Here are some examples of how the appearance of the urine may change. You may get cloudy urine if there are precipitated crystals in the urine, or if a patient has infection, you may get cloudy urine. You may get brown urine if a patient has myoglobin in the urine, if they've eaten fava beans, or bile pigments, if there are bile pigments that are present. You may get green or blue urine if you have Pseudomonas, UTI, if a patient has taken certain dyes such as indigo or methylene blue, or you may get it in patients who are on amitriptyline. You may also get orange urine, again associated with bile pigments. Then what would be of interest, or which we see more commonly, red urine, which we know is associated with blood in urine, so hematuria, hemoglobinuria. So if you get like breakdown of cells either in the blood or in the urine itself, so that you get free hemoglobin in the urine, you could end up with red urine. Patients who have myoglobin in their urine, these are, for example, patients with breakdown of their muscles, like rhabdomyolysis in porphyria. And then you also get patients that have eaten certain foods, things like blackberries, beets, or rhubarb, that may have red urine. And then finally, you get yellow urine in patients that have had a lot of carrots, patients who are on rifampicin, and patients who may be dehydrated and consequently have concentrated urine. Also under macroscopic examination would be a comment on the smell of the urine. So for example, patients with diabetic ketoacidosis have been said to have fruity or sweet smelling urine, whereas patients that have had prolonged bladder retention tend to get fermentation of their urine, and so they end up with an ammonia-like smell to their urine. Then obviously, if there's infection, the odor tends to be pungent. Patients that have GI bladder fistulas may have a fecal smell in their urine. And then medications and diet may also alter the smell of urine. For example, the strong smell of garlic in the urine of somebody who has consumed garlic, or patients who are on penicillin have the distinctive penicillin smell to their urine. And then certain metabolic diseases are said to have a characteristic smell, things like phenylketonuria or maple syrup urine disease have characteristic odors. So the second aspect of the urinalysis or the urine examination is the chemical analysis of the urine. Nowadays, we use what is known as a dipstick, which uses calorimetric methods to provide us with a semi-quantitative analysis. So essentially, it's just a strip that has been embedded with pads, and these pads contain reagents. And so what's actually happening when you dip this strip into urine is that you have these various chemical reactions happening, and then there's a corresponding change in color that tells you whether or not your test is positive, how positive, or whether the test is negative. So in terms of the procedure of carrying out this dipstick, the first is to remember that because it's a chemical reaction, the dipstick has to be stored according to the specifications of the manufacturer. Part of this means that you do not expose the strips to the extremes of temperature. You keep them dry and away from direct sunlight, and you store them in the provided container. I've often seen sometimes people borrowing dipsticks from other wards stored in a paper container. So that is not appropriate. It's a recipe for getting wrong results. And also finally, to remember that the manufacturers give us how long we must wait after we've dipped the strip into the urine before reading the results. This will avoid getting erroneous results. I came across this article, very good, on the procedure for performing a dipstick from Geeky Medics, and I would urge everyone to head over to that website and read the article in detail. But in summary, we are urged to make sure that before using the dipsticks that have been well stored, as discussed in the previous slide, we ensure that we check the expiry date of the dipsticks, and then maintain the integrity of the remaining dipsticks in the container by making sure that we close the airtight container. And then when inserting the dipstick into the urine specimen, do it in one movement, making sure that all the reagent strips are immersed. And then when removing the dipstick from the specimen, remove any excess fluid by tapping the dipstick, the tip of the dipstick, to the edge of the container, and then place it in a horizontal position so as to avoid runoff from other reagent squares going to cross-contaminate other areas. This would interfere with the results. And then once that's done, place your dipstick in a horizontal way on a pre-prepared paper towel and read off the results according to the times provided by the manufacturer. And then once you recorded your results, don't forget to wash your hands. The first component that we're able to measure with urinary dipstick is the specific gravity. As you know, the specific gravity is a ratio comparing the density of whatever substance to the density of an equivalent volume of water. So for clinical purposes, really, specific gravity correlates with the osmolality of the urine, and most sticks are able to measure specific gravity between 1 and 1.030. So isosmolar specific gravity would be like 1.010. So anything below that would be considered hyposmolar urine, and anything above that hyperosmolar urine. So low specific gravity is associated with maximal water excretion, whereas high values greater than 1.025 associated with maximal urinary concentration. In the clinical setting, specific gravity gives us an indication of the hydration status of the patient. So in patients who have normal kidneys, we expect that if they're dehydrated, their urine would be concentrated, and if they're well hydrated, their urine would be dilute. If a patient is failing to alter their specific gravity with their level of hydration and sort of keeping their specific gravity at about 1.010, that would raise the possibility of them having a kidney concentrating problem. In the context of conditions such as, for example, diabetes insipidus, where you find that your patient is dehydrated, probably also has hyponatremia, specific gravity would be useful. Like if you find that your patient who's dehydrated has dilute urine, that shows that that is a patient who is having an inappropriate response to the dehydrated state, and that would raise the suspicion of either concentrating dysfunction or the possibility of resistance to the action of ADH, so therefore diabetes insipidus. Whereas in the context of hyponatremia, for example, when we're dealing with syndrome of inappropriate ADH, we would find that in a patient who is hyponatremic, their urine would be surprisingly concentrated, which would indicate an inappropriate response to the state of being hyposmolar. But it's important to bear in mind that the reading of the specific gravity may be affected in patients who have heavy proteinuria, who received contrast studies, patients who may be diabetic and have a high sugar, patients who have acidic or alkaline urine. The next parameter is the pH. Normal urine has a pH between 4.5 and 8, and essentially what's happening is the protons are reacting with methyl red and bromothymol blue, which is present in the reagent pad. So we expect in a normal kidney that if the patient has acidemia, they should be offloading protons, and so we'd expect the urine to be acidic. So if this would be helpful in an instance where you have a patient with acidemia, and yet when you check their urine pH, you find that the pH is not acidic, they have a high pH. That would suggest the possibility of renal tubular acidosis, for example. The third parameter is protein. Largely, the dipstick will be measuring albumin. We know that there are other types of proteins that are present in urine, tubular proteins, as well as immunoglobulins, which may not, the dipstick may not be sensitive to. So this would, most dipsticks will detect albumin of between 18 to 32 milligrams per deciliter. And it's important to remember that these readings are affected by concentration. So, for example, if we have a patient who is passing large quantities of dilute urine, the reading of the dipstick will be lower than similar patient who is dehydrated with concentrated urine. We can also get false positive results in patients whose urine specimens have been contaminated with, for example, detergents like chlorhexidine, in patients obviously who have gross hematuria, alkaline urine, and acidic urine would give us a falsely positive result. Apart from nephrotic syndrome, there are other things that can give us a positive protein on dipstick. These include certain types of tubulopathies, patients who are having inflammation in the kidney, like patients with glomerulonephritis, urinary tract infection, acute kidney injury, interstitial nephritis, even patients that have chronic kidney disease, patients with renal Fanconi syndrome. So just because you found protein on dipstick does not necessarily mean your patient has nephrotic syndrome. Obviously, you'd have to check their blood and correlate that with the level of serum albumin. And then the next parameter is blood. So here it's important to remember that when the dipstick comes out positive for blood, it may be detecting either hemoglobin or myoglobin. So there what's happening is that the heme molecule catalyzes a reaction between hydrogen peroxide and or toluidine, which is present in the reagent pad. So therefore, once we get a dipstick that's positive, it may actually be a false positive, meaning that we may have hemoglobinuria. Like, for example, if we have patients with intravascular hemolysis, as may happen with patients who have severe malaria, patients with glucose 6-phosphate dehydrogenase deficiency. So these offload free hemoglobin. Some of that ends up in their urine, and that can come out as a positive on the dipstick. Myoglobinuria may also lead to a false positive. Remember, myoglobinuria would result from patients who have rhabdomyolysis, so you get a release of free myoglobin into the serum that eventually ends up being filtered through into the tubules and eventually into the urine. So that can give us a false positive. Other things to be aware of would be things like povidone iodine, and then certain types of bacteria. And then the dipstick may come out negative if the acid is very acidic or if there's ascorbic acid contamination of the specimen. So when we are talking about true hematuria, so that's blood in the urine, what sort of things would cause blood in urine? There are hematological conditions. In our context, we need to think about things like sickle cell anemia, which may be associated with both microscopic and macroscopic hematuria as a result of papillary necrosis. Patients with bleeding disorders, so patients who have thrombocytopenia, patients with coagulopathies may present with blood in their urine. Infections of the urinary tract, so pyelonephritis, viral cystitis may all lead to a positive blood test on dipstick. Malignancies, renal tumors, patients that have nephroblastoma, for example, may present with hematuria. Patients that have had trauma to their kidneys, inflammation of the kidney that may not necessarily be associated with infection, things like glomerulonephritis. Sometimes in patients with nephrotic syndrome, we get microscopic hematuria. In patients who have stones, they may end up with true hematuria, patients with hypertension, patients with infections with parasites like schistosomiasis, and even just after exercise, patients may end up with blood. So that's the list of things that can lead to a positive for blood on the dipstick. So given the fact that apart from true hematuria, myoglobinuria and hemoglobinuria can also give us a positive blood test on dipstick, it's important that we confirm the finding of blood in urine by following it up with microscopy. So this is a very interesting, very good course on the internet which talks about bedside urinary microscopy, and I'd encourage everyone to take time to go to this website and go through the course. But essentially, these are two micrographs that show two types of red blood cells that may be found in urine. On the right are what are known as dysmorphic or distorted red blood cells. This is indicative of blood that is of glomerular origin. So these, you can see the shapes are distorted. They've had to squeeze through the glomerulus to get into the urine. So suggestive of a glomerular cause, as opposed to the image on the left where the red cells are nice and round, discoid and undistorted. That is suggestive of bleeding that's coming from the lower urinary tract or the ureters, and these are known as isomorphic erythrocytes. So it's important to follow up firstly to confirm that indeed the positivity is due to hematuria, so you see red blood cells, then to differentiate the different kinds of red blood cells, whether dysmorphic or isomorphic, because that will give us an idea of what the possible differentials for the bleeding could be. And then in addition, we said that patients may present with this positive dipstick either because of hematuria or because they have hemoglobinuria or myoglobinuria. Another thing that one can do if they have access to a centrifuge is to spin the urine, and the image on our left there shows two specimens. One contains urine that has true hematuria, so there's blood in that urine. And the second sample of urine will be a urine specimen containing free hemoglobin, so hemoglobinuria or free myoglobin. After we spin or centrifuge the urine, because the urine specimen that contains blood that has hematuria has cellular components, those cellular components which are denser will tend to drop down to the bottom of the tube and leave a clearer supernatant. Whereas in a patient who has hemoglobinuria or myoglobinuria, even after centrifugation, the discoloration of the specimen remains uniform. So this is a simple test that one can carry out if they have access to a centrifuge to try and differentiate whether your patient has true hematuria. Then, just to get it out of the way, let's say supposing we find a patient that has findings after centrifugation, findings suggestive of a myoglobinuria or hemoglobinuria, meaning that after centrifugation the specimen does not separate into a cellular component and a non-cellular component. How can one differentiate between hemoglobinuria and myoglobinuria? So if obviously one has access to laboratory investigations, the thing to do would be to measure serum creatinine kinase levels, and in patients with rhabdomyolysis, the creatinine kinase tends to be greater than 1000, which would be suggestive of a myoglobinuria. But in instances where we do not have access to this, we can again use the centrifuge, but this time use blood. And after using the centrifuge, we can differentiate hemoglobinuria from myoglobinuria by evaluating the plasma color. So after we centrifuge, the plasma, if it is hemoglobinuria, will be discolored. It will be a pink or red plasma color, whereas for myoglobinuria, it will not. Just to get that out of the way. The dipstick also detects glucose. And what's happening here is that the glucose is oxidized by gluconic acid and hydrogen peroxide, and then it reacts with a pigment or chromogen that's present in the reagent pad on the strip. So it's important to remember that you may get a false positive from certain oxidizing detergents. You may get a false negative if there's contamination with keto acids or aspirin. And then obviously the major cause of glucose in urine would be diabetes mellitus. So an overspill where the serum glucose has gone up, the transport maximum of the proximal tubules is surpassed, so you end up with a spillover of glucose. So that would happen in patients with diabetes mellitus, or patients that are having some kind of stress response which is associated with hyperglycemia. And then patients with tubulopathies, like patients with renal Fanconi syndrome. And then there's some rare genetic conditions where the glucose transporters are defective, and so you end up with glycosuria. Ketones in urine. So you're getting these ketones reacting with nitroprusside on the reagent strip. Ascorbic acid, mesna, that we use when we're giving patients with treating patients with cyclophosphamide, levodopa, captopril, N-acetylcysteine may actually give us a false positive. And ketones are positive in patients who may have diabetic ketoacidosis, patients who are in the starvation state, patients who may be on a ketogenic diet, like patients with seizure disorder and they've been put on special ketogenic diets may end up with ketones in their urine. The dipstick is also able to pick up white blood cells in urine. It does this by detecting the presence of leukocyte esterase that then react with the reagent strip. Leukocytes in urine are associated with urine, but any kind of inflammation in the kidneys or even in organs surrounding the bladder can actually lead to leukocytes in urine. So positive leukocytes associated with urinary tract infection, patients who have interstitial nephritis, glomerulonephritis. We've seen positive leukocytes in patients with AKI, patients who have fever, patients who have infections elsewhere other than in the urinary tract may all have a positive test on dipstick for leukocytes. We may get a false positive in patients that have been treated with carbapenems like meropenem and imipenem, and as well as patients who've received clavulanic acid or patients that have consumed beets. The test may give us a false negative result when patients are treated with antibiotics such as gentamicin or nitrofurantoin. The dipstick also measures for the presence of nitrites. Nitrites are derived from dietary nitrates. When dietary nitrates are converted by certain bacteria into nitrites, so these are obviously associated with and are more specific for urinary tract infection, but they may be falsely negative if you have infection caused by certain types of bacteria that do not are not able to convert nitrates into nitrites, bacteria such as Enterococcus, or in patients where the urine has been incubated in the bladder for less than 4 hours. Finally, bilirubin and urobilinogen. So these are derived from the metabolism of heme by the liver. So we would expect that there would be an increase in bilirubin in situations where you have increased hemolysis, and in situations where you have liver dysfunction. We would use the urobilinogen in cases where you have complete obstruction of the biliary tract. The urobilinogen, because of the disruption of the hepatic circulation, we would find that there would probably be no urobilinogen. These are non-specific, but we could use them like that. The final component of a full urinalysis is the microscopy. Under microscopy, you would be expected to comment on cellular components. You'd be looking for casts. You may see crystals. You may actually see organisms. Organisms such as the schistosoma, for example, or at least their ova. You may actually see bacteria. So this is not something that we routinely do on our ward. So I will refer you to the online course that I spoke about. But suffice it to say that under cellular components, in terms of something that we do on the ward, we could look at the morphology of the red blood cells, and for the casts, the crystals, the organisms, we would work with the lab to try and define that. Thank you so much for taking time to listen to this talk. Thank you.